Okay, I would like to thank Jane and the forum for inviting me to talk here. I'm going to talk about something slightly different, although related to TTCs, and I'm going to talk about the what is called uncertainty, extrapolation, or safety factors that are derived once you have your results from your animal test to derive a safe dose for humans. And the way that's normally done, there you have quite good dose response with several groups. You do statistical testing. You have the lowest group, dose group at which you see or you detect an effect statistically, and you take the value below that as your NOEL that you probably know. And once you have your NOEL to derive something, because that's seen in animals, quite a homogeneous group of animals, you then divide that generally by 100. I'm talking here about chronic oral toxicity. There are other factors if you have other routes of exposure or if you have subchronic studies, but I'm only going to concentrate on the 100 data. And the idea here is when you do that, you sort of, I should explain that sometimes you can see an effect. There can be an effect at the NOEL. You don't really know where you might be on the curve, but you might not be able to detect it. And when you divide by 100, you'll expect, or the idea is that you would be below a threshold. And we decided to look at this as quite important. It wasn't in the context of TTCs, but in the context of mixture risk assessment. And particularly, you have different mathematical models to look at mixtures. You have to have the same compounds who have the same effect. If you know they act by the same mode of action, then you use a mathematical model where you add up the effect along the dose axis, the x-axis, where compounds sort of act as dilution of one another. But if you have different modes of action, then you can use a different model that's called a response addition, where there you sort of add up along the y-axis, the response. And then you can have interactions which you can't really predict mathematically. And what's important when you're using response addition, if you accept that model, you have different modes of action. If all your different compounds here have 3 compounds, if they're all below a threshold where have 0 effect, when you add these up along the response axis, then you have 0. And that's been used as an argument for ignoring any kind of mixture effect as long as you've got dissimilar modes of action, or that's proposed in that way. But what's important is if you're not absolutely sure that you've at an absolute 0 there, even a small mistake, if you have enough substances, can lead to quite a substantial effect, mixture effect. So we started looking at the default value for the safety factors. And they are, we called it urban myths because there are a number of things that you will hear about the level of conservatism of this value that are not necessarily written or not often written, but they are heard at conferences, etc. And we used urban myths. There I've got an illustration of the yellow and red card, because these are stories that are passed on mostly orally, but nobody's really checked where they come from, whether they are true or not. And I think in Germany they have this story that the yellow card is in the front pocket and the red card is in the back pocket of the referee, because when they had black and white TV, you couldn't see the difference unless they were in different pockets. But nobody knows if that story is actually true. And some of the things that are being said about the default value is that it's intended to protect against mixture effects, that it's large enough that it will protect against mixture effect. Another thing is that it's a worst case scenario, and very often you hear that they're overly conservative. So it doesn't need to be as big as 100. And the way we address that is by looking at sort of the historical background of where this value of 100 came from. That's where we look at the first 2 assumptions about these. And finally, we looked at some of the data that are behind the differences that this factor is meant to account for. So first, as the uncertainty factor was introduced when you start deriving safe level for things that you find in food, like food additives. And it was proposed by Lehmann and Fitzhugh in the 50s. And it was meant to account for differences for the fact that you'd have to extrapolate from an animal to a human, and also for the fact that you have wider differences within the human population than you would have in your group of quite homogeneous animals. They also mentioned something about having sensitive subgroups due to illness, but the mixture effects, or what they were called at the time possible synergistic action of contaminants, was considered. And you can find other references that will also say what this value of 100 was supposed to protect for. And again, mixture effects were considered, or this value was considered to be able to protect against possible mixture effect. What happened, however, in the 1990s is that scheme proposed by Rennick was adopted by the Intergovernmental Panel on Chemical Safety. And there, this value of 100 is then split first twice to account for the differences when you extrapolate from an animal to a human, and then another factor of 10 for the differences between within the general human population. And each of those can again be subdivided to account for toxicodynamic or toxicokinetic differences. And there you can see there's no more room for mixture effects. So yes, you can quote or you can reference papers that will tell you that the default factor of 100 was intended to account for mixture effect, but that intention was abandoned 30 years ago. And there's also other documents that sort of cite the complexity or the infinite possibilities of looking at mixture effect, particularly for pesticides, as a reason for not looking at this any longer. Secondly, the idea is that it's a worst-case scenario. So if you go back to the paper that was published by Rennick in 91, before he published or he proposed his scheme in 93, he based his data on a limited data set that he'd collated about these differences between species and within humans for a relatively small number of substances. And sort of classed on that, he decided that the value of 100 or 10 by 10 was an adequate scenario, not a worst case scenario. On the basis of his database, a worst case scenario, you'd end up with a value of 10,000 and not 100. Finally, if we have to mention the level of protection, if you want to talk about the conservatism of the safety factors, and go back to the definition of the acceptable daily intake, which states as a daily dosage of a chemical during the entire lifetime that appears to be without appreciable risk. So it should be noted that there's no legally binding quantitative definition of what an acceptable or an appreciable risk might be. We know that for carcinogens, generally the value of one additional case in a million over background is accepted. And in the early 2000s, Hattis made this Stroman proposal about the level of protection, which should be for non-carcinogenic compounds, 1 in 100,000 additional case over background. If you're dealing with a general population or if you're dealing with a particularly sensitive subgroup, 1 in 1,000. And this value itself is not really debated, or nobody's really opposed the values that was proposed there. The problem is that you have to extrapolate data that you see in a small number of animals with much higher incidence than that. Several order of magnitudes below at doses that are not tested at all or cannot be tested. And depending on the assumptions you make about the shape of your dose response curve, etc., you could end up with results that differ by several orders of magnitude. So it was more criticized in terms of how difficult it is to have any precise idea of where that might be and the large uncertainty or the large error you might make in trying to estimate this level of risk from the animal data. Then we moved on to looking at some of the data sets that are available to look at how really conservative or how fit for purpose the value of the sub-factors that were proposed are. And the first thing we looked at was the differences, or when you extrapolate from animal to humans. And the first thing to note is that you have an issue of scale when you extrapolate from animal to humans, because the doses are normally expressed in a weight by weight basis. However, a lot of the responses from animals are not proportional to the weight itself, but they're proportional to the metabolic rate, or some use the surface area. So they're proportional to the weight raised to a power. So to make it simple, larger animals on a weight by weight basis are more sensitive than smaller animals. So you have to correct for the size to start off with, and that would be a factor of 4 or 6 when you start with a rat, regardless of any differences in sensitivity and of the toxic response. It's also important to note that there are exceptions that don't agree very well with this allometric principle. If you're dealing with neurotoxicity, the relative weight of the human brain compared to that of animal, in terms of size, makes that it doesn't really agree very well with allometry, and examples include lead or PCBs. And also reproductive toxicity, because experimental animals are bred, and they are rodents, they are bred to be very fertile, to be better able to detect an effect, but that's not necessarily true of the human males. In terms of the data set that we looked at, there's 2 types of data. There are those that compare a response in an animal to the response in a human, and they do ratios. And there you're limited in terms of the type of compounds that you can look at, and most of them are pharmaceuticals, and particularly acute toxicity of chemotherapeutic drugs, of chemotherapy. And when you do ratios, we found 9 data set, and the ratios, when they do that, if you look at the median, your average response, that agrees quite well with allometry, but then if you look at how that's distributed, you can find that the value of the subfactor of 10 can be exceeded for about 20% of these chemotherapeutic drugs. The second type of data set that you can look at, those authors have decided to look at the differences between 2 different animal species on the basis that there is no reason why the differences in sensitivity to a toxic response would be different between 2 animal species than between an animal species and a human. One of the advantages of doing that is that you can look at a much wider range of chemicals because they've been tested. There we found 8 data sets, and again, the medians agree quite well with the allometric principle, but when you see how that's distributed, you find that a factor 10 would be sufficient for about 71% of chemicals. I mean, there's 29% of chemicals for which you would need a greater factor than 10. Should be noted that there's limitations with this kind of data, and that you can't really move away from that. Some of these are noted there. The maximum tolerated dose here refer to the dose in humans, and they're already associated with toxic effect. You're dealing with short-term studies of acute toxicity in the human. You're not really looking at the effects of chronic exposure. The endpoints that are compared between species are not necessarily the same either. When you're looking at data set that have used chemotherapeutic drugs, they're administered by injection, so you don't have any measure of the influence of first-pass metabolism here. The type of compounds that have been looked at are not necessarily very representative of the universe of chemicals you might be exposed to. And also, when you're looking at the effects in people that are receiving chemotherapy, these are people that are not healthy adults, so they might be already more sensitive to toxic effects. And some of these limitations might mean that it might shift the distribution one way or the other, but you can only speculate on that. We can't measure it or test it experimentally. Then when we move on to looking at the differences between individuals, there's a number of reasons why in the general population differs a lot more than a small group of lab animals. Some of them can be corrected by or can be looked at by your design, such as the age or pregnancy or gender. But others are generally because of ethical reasons in the way you treat animals you don't really look at in terms of stress or disease or the differences in diets in the general population. And again, there's much fewer data sets that have looked at these differences. There's a large one that only looked at the differences within animals. And then they use the slope of the dose-response curves because when you have a dose-response curve, what you're actually measuring is differences in sensitivity or response between different animals. And they use that for nearly 500 carcinogenic agents. And then they found that if you compare that, your default factor of 10 would be sufficient for about 88% of chemicals. And then there's another 2 databases that have been compiled by different authors, and there's some overlap between the 2 databases. They use data in healthy adults from therapeutic or occupational exposure. There was clinical trial data in terms of the metabolism of drugs, etc. And from there, they tried to calculate, compare that to a level of protection and calculate the number of people that would be covered by the default factor. And Rennick and Lazarus found that 162 persons per million would be covered by that factor. And Hattis et al. Calculated that if you take an average chemical, you have about 8 people in, that are not covered. 8 people in 100,000 that would be at risk. Or if you try to protect for 95% of chemicals, you have 2 to 3 people per 1,000 that would be at risk if you use these default values. Okay. And then it's important to note that that was relating to data in healthy adults. Now, there might be other reasons why a subgroup is particularly sensitive, and then you should calculate your factor differently because you want to protect sensitive subpopulation as well. And if you have a sensitive subpopulation, it's important as well when I next look at the probabilistic approaches that have been used to look at the value or the distribution of this uncertainty factor. If you don't consider sensitive subpopulation, then you introduce an error when you assume that these sensitivities are log normally distributed, because you might have it might skew, you have a larger tail of sensitive people. So the other idea is because if you take a value that's somewhat conservative for the differences between animals to humans, and then you take another value that's somewhat conservative for the differences between or within the general population, then you compound conservatism when you multiply those, and you end up having something that's far too conservative. So we also looked at authors that have done these kind of probabilistic approaches and multiplied this distribution to find, to look at what they found. And a couple of those found that you'd probably be okay with a factor of 100, but we had some issues with some of the distribution or the assumption they made. The first one is Gaylor and Caudle in terms of the database they used to estimate the distribution for extrapolating between animals to humans. They used some data that was based on 500 substances, but on aquatic species only, and they didn't correct for allometry. They didn't add the allometric factor there at all. And then there's a more recent work done by Hasegawa et al., where in terms of their distribution for the differences within the population was based on their own data set of just 18 industrial chemicals and the differences between young and newborn rats. The other authors, I mean, the distribution themselves differ, and that should be kept in mind when anyone is using a probabilistic approach, that depending on which data set you find, you might end up with a different result. So I probably would advise to try several of those and see if your conclusions differ widely. But in terms of where the factor of 100 was on this overall distribution, it's more or less between, they found more or less that it would be sufficient for about 83 to 88% of chemicals, or in 83 to 8% of cases. So we see that well, I suppose you have roughly 15% of cases that are not covered by this factor. So to conclude, I think it's important to remember that you can't be absolutely sure that your ADI is absolute zero risk. And that's important for mixture risk assessment in particular. Then whether you're protective enough depends on what is the desired level of protection, and you need to be clear about what you're trying to achieve there. And there are also intractable uncertainty when you're trying to derive something at the sort of level of protection that we would consider acceptable, that we have other uncertainty there, we can't be absolutely sure. So in terms of what we would recommend, particularly for mixture risk assessment or other for single chemicals, is to of course you can replace these subfactors by chemical specific data, and that's desirable. If you know something, that's always much better. But until you know, you'd have to have some kind of incentive to generate that data, and the default value shouldn't be set in such a way that by generating that data you end up being penalized because you end up with a factor that's greater than the default factor. So we would encourage looking at using an additional factor or trying to aim for larger margin of exposure or margin of safety. Thank you very much.